Hello, everybody. I'm Sally Spencer-Thomas, co-chair of the Workplace Suicide Prevention and Postvention Committee of the American Association of Suicidology, and welcome to our webinar, Workplace Suicide Prevention and the Role and Potential of the Employee Assistance Program. It is my pleasure to introduce our two esteemed speakers today. Dr. Jody Jacobson-Frye. She is the co-chair with me on this committee and a professor at the University of Maryland School of Social Work. She chairs the Social Work and the Workplace and Employee Assistance Subspecialization and the Financial Social Work Initiative and the Emerging Behavioral Health and Wellness Lab. She's also the co-editor-in-chief of the Journal of Workplace Behavioral Health and the co-founder of the International Employee Assistance Digital Archive. Bernie Dime is the president and CEO of Perspectives. Mr. Dime assists in creating safe and productive workplaces by providing consulting and training in employee assistance programs, work-life programs, human resource initiative issues, organizational development, crisis management, workplace incident management for HR and supervisors, and humanitarian assistance, and is a avid workplace workshop speaker across North America. So just to give you a little orientation about what we're doing here, Workplace Suicide Prevention, the National Guidelines for Workplace Suicide Prevention, is a collaborative partnership among the American Association of Suicidology, the American Foundation for Suicide Prevention, and United Suicide Survivors International. And together we're trying to elevate this conversation. We have developed these guidelines under 8 guiding principles. And today we will be focused on mental health services. So this would potentially cover all of these, but really about what we're calling empowered connection, helping workplaces give empowered, knowledgeable, warm handoffs to their mental health services, not just a brochure, but a relationship, and to promote well-being in addition to helping people through mental health challenges. When you dive into the guidelines, you'll realize that there's 9 practices involved, and we've organized these into upstream, midstream, and downstream types of practices. And today we're really going to be focused a little bit more on the downstream side of things. So managing mental health crises and mitigating risks and responding when there has been a death by suicide.
So thank you, Sally. Delighted to be here and honored to be here. I'm just going to briefly set the stage. And what we hope to do today is to teach you about 3 things. First of all, what EAPs are. And you're going to learn that not all EAPs are the same. They're very different. And we're going to promote what we think is the best. Learning how to partner with EAPs for not just clinical services, but organizational services and how they're tied together. And also to learn how important it is to have an organizational partnership with EAP.
Whenever there was an employee suicide attempt or death, the EAP gratefully was usually contacted by management to provide some crisis response and postvention services and support for survivors, but much more needed to happen. In any good workplace response to crisis, we as the EAP, as you're going to hear today, we try to work with the organization in partnership to review specifics and also to plan to prevent future crises, including suicide. We try to learn from our prior experiences to improve services and really work towards making a life worth living. Unfortunately, in most of the workplaces that I was honored to work with and to serve, when someone died by suicide, workplace leaders and other stakeholders were very quick to conclude that there were personal problems that must have caused that suicide, and very quick to eliminate any connection with the workplace. I would hear, well, that person has been going through a really ugly divorce, or we knew that she was suffering from major financial burden. And not once did an organization take any kind of responsibility or ownership to see that maybe issues about toxic workplace environments, workplace stress, or other conditions about quality of work and life could have a negative effect and ultimately contribute to suicide. In the United States, as well as in many countries around the world, EAP services are not standardized. And so that means that employers can select what types of options they want, usually from a very long list, and determine what they're going to offer their employees and usually their family members. As you see on the slide, this can range anywhere from a 1-800 number EAP, which can be very inexpensive, even free at times, where somebody calls and gets a list of referrals, very similar to what you'd get if you called the phone number on the back of your insurance card looking for mental health and substance use referrals. And all the way up to full service, or what we're starting to call top tier EAPs, which provide not only a full comprehensive range of clinical and management services, but also understand partnering with the workplace, particularly in a time of crisis, including an employee's suicide. And the model in the middle, while there's hundreds of different models, the embedded model involves EAPs that offer on-site and connected services to the workplace. And we think about the opportunities for EAP professionals to form partnerships and relationships with workplace leaders to understand the culture of the workplace and to be able to provide a more comprehensive response. So let's take a quick look today at how these programs work with workplace leaders on suicide prevention. This visual shows you in the front and center the clinical services, or what we often think of as the bread and butter services of EAPs. We provide assessment, short-term counseling, referral services, ideally 24 hours a day, 7 days a week, because we know crises doesn't happen between the hours of 9 and 5. And these clinical services also provide evidence-based treatment, including treatment for suicide, such as CAMS, the Collaborative Assessment and Management of Suicidology, which is in the process of developing training specifically for EAPs, cognitive behavioral therapy, and dialectical behavioral therapy, all with evidence to reduce suicide. Other services include grief counseling, anxiety, and programs for individuals, families, and work groups. And on each side of these are the remainder of the comprehensive services that EAPs offer, particularly in top tier models like work life, child and elder care or adult care, financial and legal problems, and then the HR leadership management consultation, where EAPs have an opportunity to think about how the clinical cases that they're seeing really provide them a view into the pulse of the workplace and can share that information with employers to think about new policies and programs and procedures. So the clinical services in a nutshell, again, really focus on having multiple access entry points, whether that be telephonic, web-based, text-based, and at all hours of the day. We get into prevention, so you'll see EAPs involved with doing gatekeeper trainings like mental health first aid or assist or QPR specifically for suicide, as well as anti-stigma training and awareness programs, partnering with workplaces in health and wellness fairs, incorporating national screening initiatives like National Depression Screening Day and more. The professional counselors are able to do a structured assessment, including a standardized suicide risk assessment, where they are then able to triage problems and identify who needs services urgently, emergently, or in a routine type of follow-up referral. An active follow-up is a major component of EAPs. So they need to, number one, make sure that for employees that are referred into the community and healthcare plans, that referral is effective and that it's satisfactory to the employee, but also that it's helping to meet the need, both from a clinical standpoint, as well as supporting overall workplace performance and productivity. Having top-tier clinical services are only one part of being an effective EAP. And in fact, a true partnership, or what I like to call a dance, between the EAP and the workplace is required to have satisfactory utilization, satisfactory quality of care, and really have an effective partnership where EAPs are used in a way that the EAP invests time in understanding the workplace culture so that they're capable of doing prevention and effective response, both in employee suicide and related issues, but also the employer needs to invest time in their EAP to understand what are the breadth of services offered and how can they be an effective champion to promote these services in a way that reduces stigma and increases barriers for help seeking.
EAPs should be seen, I think, in two ways. One, as integrators, and two, about taking a big picture approach. So with suicide, it's also even more true. So there are three phases that we deal with. One is the prevention, the other is the intervention, and the other is postvention. And so again, Jody has really talked about the need to triage and help. The postvention services are really key, and they really highlight the integration aspects. These are just a few of the areas that organizations have that are affected and deal with these suicide events, any crisis event. So what I want to talk about is steps that organizations should take. So if you have an EAP already, I think it's really important that you hold them accountable, that you make sure that they're top tier. Make sure that they're what Jody has talked about, what we've tried to lay out. Make sure also that they are suicide prevention, intervention, and postvention capable. Not every clinician that answers a phone or provides services has been trained in identifying potential suicidation, as well as to know how to intervene at different levels of the process. Really important. And more importantly, as I showed in my example, promote the services. Really let people know it's available, how to access it, and again, really make sure that you're evaluating the impact that it is or is not having. If you don't have an EAP, find one, and find one that's top tier. Just so you know, every company has an EAP or something called an EAP. 97% of companies have EAPs, of companies with more than 5,000 employees have EAPs. 80% of companies between 1,000 and 5,000 have EAPs. And 75% of companies lower than 1,000 people have EAPs. And you know, they need to be prepared to deal with suicide. And finally, don't be cheap on this benefit. The cost of even an expensive EAP is literally less than a 0.5% of the cost of the total healthcare premium. I will say that the cost of not having an EAP is far greater. One situation could make things even worse. Finally, on the last slide, I do want to say we do feel that there are certainly places and resources that you can have. We're not going to go into detail, but every one of these resources is a place you can go to find out how to evaluate, find, and use your EAP and push them to service you in the way that is best. I want to thank you on behalf of Jody and I.